Good evening, sir. I, Shuman, on behalf of Shield Healthcare, welcoming you and all the participants in today's webinar. And the topic of the today's webinar is urinary tract infection in pregnancy. And our guest speaker is Dr. Sachin Ajmena, sir. So before moving into the webinar, let's have a look on our Shield Connect page. This is your Shield Connect page. You can find different blogs in various topics written by many eminent doctors. And in this past webinar tab, you can find that already we have conducted various webinars in different topics as well. This is the important blogs, that is respiratory immunity blogs you can find over here in this COVID era time. And these are the PCOS awareness blogs. You can find different lectures of many eminent doctors in different regional languages as well. As you can see, that is English, Hindi, Malayalam, Telugu, Kannada, and many more. And the most important thing is our key opinion leaders. And currently, almost 250 doctors are currently supporting our knowledge sharing platform, that is Shield Connect. So I request all the participants to please look on this website, as it is a very informative and emerging website. And now it's time to move into our webinar, and it's my pleasure to introduce Sir. Sir is MD, DNB, MNAMS, FCPS, FICMCH, DGO, DFP, DHG. And Sir is the consultant gynecologist currently associated with Disha Hospital, Mumbai. Sir has several awards and prizes, including Promila Bharati Young Scientist Award, Best Youth Council Member Award, Best Managing Committee Member Award. Sir has a co-editor book on Gynecology Oncology Simplified, a practical approach. And Sir has many publications in national and international journals of world repute. With this short introduction, I request Sir to take over the session. And meanwhile, I request all the participants for their active participation. And please post your queries on the QA dashboard of the Shield Connect page. So once the webinar will be over, we shall have a short discussion with the questions, Sir. So thank you very much, Sir. Over to you.
Sure. Thank you, Dr. Suman, for the kind introduction. Start my screen sharing. Yeah, I hope you can see this now.
Yes, sir.
So good evening, everybody. Today we are going to talk about one of the very important topics that we deal with day in and day out, that is urinary tract infection. Okay, so urinary tract infection, it is said to be the second most common infection in community practice. It's a common infection that is diagnosed in outpatient as well as in the hospitalized patient, generally self-limiting, but can be recurrent, can occur in males, females, happens in all age groups. So basically, urinary tract infection is infection of the urinary system causing an inflammatory response. So worldwide, it is said that nearly 150 million people are diagnosed with UTI in a year, costing a global economy in excess of nearly $6 billion US. So it's really a problematic worldwide, not only in India. So by convention, UTI is defined either as a lower tract, that is acute cystitis, or the upper tract infection. It can be asymptomatic, what we call as asymptomatic bacteriuria, or it can be a symptomatic disease. Asymptomatic bacteriuria occurs in the absence of symptoms that are attributable to bacteria in the urinary tract and does not usually require treatment. UTI has more typically be assumed to imply symptomatic disease. However, for us, even asymptomatic bacteriuria is quite important. During pregnancy, urinary tract infection is one of the most commonest bacterial infections. It can occur as asymptomatic bacteriuria, acute cystitis, or acute pyelonephritis. So the definition what we talk about is a recurrent UTI may be defined as 3 or more urinary tract infections in pregnancy. Recurrent UTIs occur due to bacterial reinfection or bacterial persistence. Now, what do we mean by persistence and reinfection? Persistence means that it involves the same bacteria. It has not been eradicated after your treatment. But the treatment is what you have adjusted based on the sensitivity reports. A reinfection is recurrent with a different organism or the same organism in more than 2 weeks after you have had a sterile intervening culture. So this is the definition of what we call as recurrent UTI, persistent UTI, or reinfection in the UTI. So going with the epidemiology, nearly asymptomatic bacteriuria is found in nearly 10 to 13% of the patients with acute cystitis in 1 to 4% and pyelonephritis in 0.5 to 2%. Though the incidence of bacteriuria in pregnant women is only slightly higher than the non-pregnant women, the progression to pyelonephritis is nearly in 40%
Sorry, sir,
of the
for the
Yeah.
interruption, sir. Your voice is somehow breaking.
Okay, just a minute. Okay, better now?
It's okay, sir.
Okay. So asymptomatic bacteriuria, we said would happen in nearly 10 to 13% of the patient. In pregnant women, it is only slightly higher than non-pregnant, but the chance of progression to pyelonephritis is very high, and hence the importance of asymptomatic bacteriuria. So incidence of UTI is said to be more common in females as compared to males, and it is estimated that nearly 35% of healthy women suffer from symptoms of UTI at some time in their life. Okay, so nearly one third of the women would have experienced UTI at some more point of their time. And most often it happens in the reproductive age group, and incidence increases in postmenopausal women due to obvious reasons. We know that the hormones are deficient. So what are the risk factors? So women in the reproductive age group, because of the sexual behavior, certain contraceptives can cause UTIs. Postmenopausal women, diabetes, pregnancy, immunosuppression, long-term urinary catheter, urethral obstruction due to stone structure. These are all risk factors for development of UTI. So why is there greater susceptibility of UTI in women? So the reason lies in the anatomy. The female urethra is short in length, nearly 4 centimeters compared to male urethra, which would be around 15 centimeters. Also because of the proximity to the anus. And the habit in many Indians of wiping from back to front after a bowel movement. So, wiping from back to front brings the bowel infections, that is germs or the bacteria, the bowel as well as the vaginal as well as the perineal bacteria are, forced towards the urethra. So these are the reasons. And why is it more common in pregnancy? It's because of the physiological changes that happen during the pregnancy. Kidney size increases by approximately 1.5 centimeters. There is dilatation of renal calyces during hydronephrosis like picture, which can cause urinary stasis, increasing the risk of pyelonephritis. Also, there is an increase in the glomerular filtration rate, renal flow rate. This changes affect the pharmacokinetics of the drugs that are used in the treatment, and sometimes some of the drugs are not too effective. Also, the growing uterus compresses laterally and displaces the ureterus at the pelvic rim. The urethral compression and the effects of progesterone cause a significant urethral lengthening, dilatation, and thickening. This changes give rise to hyperurethra, sometimes giving rise to obstructive nephropathy, increasing the risk of infection. Also, due to the persistent pressure on the urinary bladder, there is not thickening of the bladder fiber. This also increases the bladder pressure from 8 to 20 centimeters of water. Because of the increased pressure, there is a significant vesico-urethral reflex which would happen during pregnancy, causing the ascending urinary tract infection. So your asymptomatic bacteriuria can get quickly converted to cystitis, which can spread to becoming pyelonephritis. So the other risk factors that are there for recurrence are the pre-pregnancy history of UTI, low socioeconomic status, sexual activity, older age, multiparity, anatomical urinary tract abnormalities, sickle cell disease, diabetes. These are all attributed to recurrent UTIs. So the most important risk factor that we should take care of during pregnancy is, and this was the paper that was published in epidemiology, predators of urinary tract infection at first prenatal visit. So urinary tract infection prior to prenatal care initiation and a pre-pregnancy history of UTI is the most important risk factor during this pregnancy, which we all should be aware of, and we should note that always in our history. So what are the natural defense mechanisms for urinary tract infection? The urine becomes acidic during UTI, which kills most of the bacteria. However, this acidic urine also gives rise to certain symptoms. Dean mannose in the urinary tract does not allow the bacteria to stick to the uroepithelial wall. Now, the Dean mannose plays an important role for preventing the infection. Bacteria moving upwards are regularly flushed by urination. So increased frequency of urination is sometimes helpful in the women, and we should also be telling the women to be voiding their bladders regularly, especially during pregnancy. So the stages of urinary tract infection, first and foremost, is the colonization. The pathogen colonizes in the urethra and then ascends towards the bladder. So in the bladder, it gets attached to the uroepithelium and it starts replication and potentially forming biofilms. What are biofilms will come to later. So here the infection gets localized in the bladder, it starts replicating, and from the bladder, it can ascend to the ureters and give rise to pyelonephritis in the kidney. And the pyelonephritis can finally lead to acute kidney injury. So, right from asymptomatic bacteria, this is how the urinary tract infection can progress if we don't intervene at the right time. So, the symptoms would depend on which part and how severe is the urinary tract infection. And the most common etiology, the bacteria causing UTI, is E. coli, predominant pathogen in nearly 80 to 85% of the cases. Most of the time, on the culture, you are going to get this organism. And in only 5 to 10%, you would get Staphylococcus saprophyticus. In addition, Klebsiella, Protea, Pseudomonas, Enterobacter. All this, all the bowel organisms can easily and commonly can cause UTI. So E. coli, we all know gram-negative, going back to microbiology, rod-shaped bacterium commonly found in the large intestine. It can be pathogenic or it can be non-pathogenic. Pathogenic E. coli are attributed to cholecystitis, bacteremia, UTIs, traveler's diarrhea, etc. All this is caused by pathogenic E. coli. Staphylococcus saprophyticus is a gram-positive bacteria. It has a capacity for selective adherence to the human urothelium. And it is a normal flora of the female genital tract and perineum. And that's why it is the second most frequent causative agent of the acute UTI. Other bacteria, Klebsiella, Proteus, Enterobacter, Pseudomonas can all be attributed to causing UTIs. So, infection, the commonest route is the ascending through the urethra, especially the organisms of enteric E. coli and other enterobacters. These ascend through the urethra and cause infection. Blood routes, Staphylococcus aureus, Candida, Salmonella, and through lymphatics also the infection can happen. But these all are rare infection. Commonest route is ascending through the urethra. UTI during pregnancy, why is so worried in addition to it spreading faster to develop pyelonephritis, it is also associated with IUGR, anemia, preeclampsia, preterm delivery, increased incidence of cesarean section, low birth weight, as well as amnionitis. All this have been independently attributed to urinary tract infections. Now, how do we screen or how do we check for urinary tract infection? So we have urine routine microscopy. There is a leukocyte esterase and nitrite dipstick. When the prevalence is 2% or less, there's something called as a dipstick culture technique and urine culture sensitivity, which is the gold standard. So the diagnosis is based on detection of pus in urine, WBCs in urine. Generally, 5 to 7% for high coffee is considered as significant when we do our urine routine microscopy. And urine culture is supposed to be the gold standard. But for every urine infection, we need to explain to the patient to give a proper sample. Now, this proper sample can be obtained, which is called as a midstream clean cat sample. So there is this procedure by which the patient should be advised to collect the sample, which is very important and which we often miss. And we just tell the patient or sometimes we provide them the bottle and tell because urine leakage. Okay, so it should not be the case. Advise the patient to have a clean cat sample. So with one hand, the labia should be spread and with the other hand, a soap moistened towel to wipe the urethral meatus downwards towards the rectum and then discard the towel. Void the initial portion of the bladder contents into the toilet and catch the middle portion of the bladder contents in the sterile collection container while keeping the labia spread with the hand. So this is the way we should advise all our patients to collect the urine sample. Only then we can reach to an accurate diagnosis. Otherwise, we get a contaminated sample. So in routine urine analysis, positive result for nitrite, leukocyte esterase, WBC, RBC, and protein all are suggestive of urinary tract infection. Sometimes bacteria can be found in the specimen and which can help in the diagnosis. The specificity of urine routine to identify the infection is around 97 to 100%. However, sensitivity is very low, around 25 to 67%. False positive rate is very high. 1 to 2 bacteria in an unspun catheterized specimen or more than 20 bacteria per high power field in a spun urine correlate closely with a bacterial colony count of more than 10 raised to 5 colony forming units per ml on a urine culture. Okay, so urine analysis good to detect whether there is UTI or no, but which type of UTI you need to go ahead and do a culture. So this is a leukocyte esterase nitrite dipstick, and the result is seen is in form of this. I mean, just a dipstick, and you see the color and you find out. So this is a rapid method of testing for urinary tract infections. So urine culture, going on to urine culture, it's a standard method for evaluating UTI during pregnancy. When you find more than one organism in culture, you have to think about whether the specimen is contaminated. If it is, you think so, the specimen should be sent for evaluation. A second specimen should be sent for evaluation as soon as possible. Whenever there is a delay in sending the sample or the specimen, it should be refrigerated at 4 degrees centigrade if it cannot be transported immediately. This is very important. If you let the sample remain, there are high chances of contamination. If you find a bacterial count that is less than 10 raised to 5 colony forming unit per ml with 2 or more organisms, then it's a contaminated sample and you need to collect a fresh sample. In patients with pyelonephritis, you often don't have a white blood cell cast. So whenever you have a sample and it shows more than 2 organisms, or it's most often it is a contaminated specimen. If it is showing showing only 2 organisms, but if the colony forming unit count is less than 10 raised to 5, again, consider it to be a contaminated sample and resend the culture. Positive culture is diagnosed by 2 consecutive voided specimens with isolation of the same bacterial strain at 10 raised to 5 colony forming unit per ml or higher, or a single catheterized specimen yielding a colony count of at least 100 colony forming units per ml. So 2 ways of collecting clean catch. If the patient is providing with the sample, you should have a count of at least 10 raised to 5 colony forming unit. If the patient is catheterized and you are using the midstream sample, 100 CFU per ml would be fine. Culture results can be used to identify specific organisms and antibiotic sensitivities. Cultures yielding significant growths of mixed organisms should prompt a search for underlying renal calculi. If you're getting multiple organisms and all in more than 10 raised to 5 colony forming units, then you should search for an underlying renal calculi, which is the most common cause of having infection with multiple organisms. So the clinical presentation, most of the time we find persistent or asymptomatic bacteriuria, which you would pick up only on a urine culture. However, untreated case can present also as acute cystitis or acute pyelonephritis. So asymptomatic bacteriuria definition according by the IDSA or the Infectious Disease Society of America is significant bacteriuria in asymptomatic women defined as a bacterial monoculture in a quantity of more than 10 raised to 5 CFU in 2 consecutive midstream clean catch samples, as we just discussed. And it is recommended now by American Academy of Pediatrics and even ACOG that all patients, all pregnant patients at first prenatal visit should be screened for asymptomatic bacteriuria or at 12 weeks, whichever is earlier. Why is it important? We already discussed because 40% of these women will develop symptomatic infection during pregnancy and cause various complications. Acute cystitis affects nearly 1% of all pregnant women, and it is almost always a result from the ascending infection of long-standing asymptomatic bacteriuria. Symptoms, we all know, dysuria, frequency, urgency, suprapubic pain, hematuria, all this would be seen. Lower urinary tract symptoms with pyuria accompanied by a sterile urine culture may be caused by urethritis from chlamydia trachomatis. One thing that we need to keep in mind, this is rare, but sometimes you get patient complaints of acute cystitis, but the urine culture is sterile. In this case, think about chlamydia trachomatis and treat accordingly, and the results are very good. Acute pyelonephritis, most common serious medical complication of pregnancy, leading cause of septic shock during pregnancy. Pyelonephritis is generally seen unilateral, more common on the right side in more than half of the cases, and bilateral in one-fourth of the cases. Signs and symptoms: abrupt onset of fever and chills, aching pain in one or both lumbar regions, anorexia, nausea, vomiting, and tenderness as costovertebral angles. So, any patient presenting with fever, first and foremost in pregnancy, do think about pyelonephritis. Gold standard for diagnosis is renal biopsy, but it is not practical. Hence, a combination of symptoms with a full blood count, inflammatory markers, renal function test, blood culture, urine culture, and sensitivity testing is what would lead us to the diagnosis of acute pyelonephritis. Now, there are severe medical complications that are associated with pyelonephritis, which is you can have frank pulmonary edema, patient can go on to ARDS, endotoxin causing hemolysis, also causing anemia, and there is transient renal dysfunction. So, in short, it's a serious medical condition which needs immediate admission. Obstetric complications associated with acute pyelonephritis are preterm labor, preeclampsia, chorioamnionitis, and postpartum endometritis. Fetal complications of low birth weight, prematurity, developmental delay, mental retardation, perinatal mortality, all associated with acute pyelonephritis. Differential diagnosis: patient presenting with fever during pregnancy, chorioamnionitis, appendicitis, placental abruption, and infarcted leiomyoma are the differential diagnosis. However, once you examine, see the reports, the diagnosis is quite clear. UTI, now going on to management, appropriate antibiotic treatment in women with uncomplicated cystitis leads to significantly higher symptomatic and bacteriologic cure rates, and it's a better for prevention of reinfection. Empirical antibiotic treatment is usually what we all do. I mean, once a patient presents with, and it's a first treatment to be administered with UTI. However, this should be, if you have screened the patient before, you would be in a better position to treat them when they present later. So first and foremost, the most important thing is the behavioral methods. I mean, this we should be teaching to all our patients, and so as to reduce the incidence of urinary tract infection. First is avoid bathtubs. Second is wipe from front to back after urinating or defecating. And this is one of the most basic thing that we can teach to all the girls also, so as to be preventing UTIs. Wash hands before using the toilet. Use washcloths to clean the perineum. Even the perineum needs to be cleaned, after passing urine or defecating. Use liquid soap to prevent colonization from the bar soap. Many times the bar soap is itself colonized with many bacteria, and the soap used by many people can cause transmit infection. Changes in coital patterns, position, frequency, postcoital antibiotics can offset recurrence in at-risk individuals. Another thing is increasing fluid intake. This increases frequent voiding and high volume dilute urine, all of which will reduce the risk of symptomatic infection. Emptying the bladder following sexual intercourse. This washes away the organisms that are massaged up the urethra from the perineum into the bladder during coitus before they have the chance to replicate in urine within the bladder. So emptying the bladder after sexual intercourse, increasing fluid intake, double voiding so as to ensure that there's no residual urine that is left in the bladder post micturition, and cleaning of the perineum. These are the things that we should encourage in all our patients so as to reduce the incidence of UTI. Management, we all know of UTI is the antibiotics, oral antibiotics commonly used, nitrofurantoin, fosfomycin, p-mesalenam, fluoroquinolones, which we don't use in pregnancy, and then we have the beta-lactam antibiotics, and which can be used. So these are the commonly used antibiotics that we use in the management of UTI. Now, for asymptomatic bacteriuria, once you have detected the patient to have asymptomatic bacteriuria, patient can be treated by all of these antibiotics, and amoxicillin or ampicillin as a single dose, nitrofurantoin in a single dose. If you find there is no relief, a 3-day course can be advised. And sometimes in cases of failures, even 4 times a day of nitrofurantoin should be given for 21 days. But once you treat asymptomatic bacteriuria, you need to repeat the culture after 2 to 3 weeks to find if the infection has been cured of or not. Follow-up of asymptomatic bacteriuria, as we said, there should be a periodic screening after therapy, since as many as 1/3 of them will experience a recurrent infection. Follow-up cultures should be obtained 1 to 2 weeks after treatment and then repeated once a month. So every monthly, once the patient is detected to be positive for asymptomatic bacteriuria, treat the patient, follow up after 1 or 2 weeks, do repeat the culture. If the culture is negative, every monthly, do keep on repeating urine cultures. Management of persistent recurrent bacteriuria is then you need to, again, if it's a persistent and recurrent, treat according to how your sensitivity report is showing. Or else nitrofurantoin 50 to 100 milligram at bedtime needs to be continued till up till the last few weeks of pregnancy. Point of note, nitrofurantoin cannot be used in patient with G6PD deficiency. Also stop in the last few weeks of pregnancy, as it can cause hemolytic anemia in the newborn. Postpartum urologic evaluation may be necessary in such patients with recurrent infection because they are more likely to have structural abnormality of the renal system. Going on to acute cystitis management, in addition to whatever behavioral methods we have talked to, the first line of treatment again would be your antibiotics such as nitrofurantoin or fosfomycin, urine alkalinizing agents, cranberry juice, which also act as a urine alkalizer, is used to treat urine infection and inhibit the symptoms. So all these things like cranberry juice, urine alkalinizing agents do help in the rapid improvement of the symptoms. You know, the pain that is there, the suprapubic pain and all, can be relieved if all of these are done together. Acute pyelonephritis, the patient needs to be hospitalized, obtain urine blood culture, evaluate the hemogram, serum creatinine, monitor the vital signs, and establish urine output of more than 50 ml per hour. And most of the times, this patient would need an ICU treatment because a lot of things need, because they can quickly go into ARDS and septicemia, especially during pregnancy. So acute pyelonephritis, thromboprophylaxis, tocolysis is often necessary when we are managing a patient with acute pyelonephritis, and antenatal steroids should be given because of high chances of preterm labor and delivery. Antimicrobials of choice in acute pyelonephritis, ceftriaxone, cefepime, or amoxicillin with clavulanic acid are preferred. Severe acute pyelonephritis, ticarcillin with clavulanic acid or piperacillin with tazobactam is preferred in such patients. Now, these are the US FDA categories of medicine which we use generally in UTIs. So you can see most of this are amoxicillin, cephalosporins, piperacillin, azithromycin, erythromycin, meropenem, clindamycin, nitrofurantoin, all belong to FDA category risk B, sorry. And so this can be safely used during pregnancy, and we should not be hesitant to use this during pregnancy. Fosfomycin, a new antibiotic that can be taken as a single dose. It's a broad spectrum antibiotic. Again, it's a category B drug, and it's a single dose available in a 3-gram sachet. Patient compliance generally is very good with this antibiotic. So it's generally 1 sachet of water dissolved in around 90 ml of water can be taken with food or without food, and it's a recommended dose is a single dose. So it's found to be very good in cases with acute cystitis. So UTI generally guideline recommendation, fosfomycin is now recommended as a first choice drug along with nitrofurantoin. Alternatives are cephalosporins, and if you know the exact resistance pattern of E. coli, accordingly the drugs can be used. What if UTI does not respond to a treatment? Many times we have been treating UTI, but it just does not respond to the treatment. Now, the cause of persistent infection would be because in case if there is any urinary tract obstruction, abnormal uretro or pilocalycial dilatation, intrarenal or perinephric abscess, or nephrolithiasis. So think of all of this if the patient is not responding to the treatment. Also, once you find that not responding to treatment, you need to go ahead and do a KUB of the USG or one-shot intravenous pyelogram. Again, we are worried about the amount of the radiation that the patient may be exposed to, or MRI may be better in case we want to detect any abnormalities within the urinary tract. If there is any obstruction relief is the most important thing. and a double J stent can be placed during pregnancy, no issues with that. Percutaneous nephrostomy or surgical removal of stones should be done accordingly if there is a persistent infection. What is the cause of recurrence in low count bacteriuria or even negative cultures? The answer lies in something that is called as intracellular bacterial colonies forming a biofilm. Now, biofilm is one of the concepts that we need to understand, and this is generally attributed to uropathogenic E. coli. The E. coli, it invades the urothelial cell lining the urinary bladder, and it forms an intracellular, within a cell, it forms a bacterial community, which is called as biofilm. Now, this is generally protected, and your normal antibiotics cannot penetrate the biofilm, because of which many times there we have treatment failures. Also, the infection would not pass off easily, and it would not be detected in normal urine culture, and it can cause recurrence. So, culture negative infection presenting with unexplained dysuria and urgency is what we call as interstitial cystitis or the bladder pain syndrome. So, whenever a patient presents and the urine culture is negative, think about interstitial cystitis, which we often miss. Now, prevention of a recurrent infection, you need to continue antibiotic prophylaxis till the end of pregnancy in the form of tab and nitrofurantoin. Intake of cranberry juice, we can recommend the patients to consume more of cranberry juice and concentrate, or which is a concentrated equivalent of a cranberry juice, which is effective in preventing recurrent UTIs, maintaining local hygiene, drinking at least 3 to 4 liters of water in a day. Women who are sexually active can be advised to practice postcoital voiding. I mean, these are the tips to prevent a recurrent infection. So to conclude, recurrent bacteriuria in pregnancy is common and a serious cause of maternal and perinatal morbidity and mortality. Clinical presentation include asymptomatic bacteriuria, acute cystitis, and pyelonephritis. Screening urine culture at the first visit or at 12 weeks of pregnancy is recommended by both ACOG as well as RCOG for detection of asymptomatic bacteriuria. When choosing an antimicrobial, pharmacokinetic, and bioavailability of the individual drug in pregnancy must be considered along with the resistance profile of the microorganism. But most importantly, simple behavioral changes and continuous antibiotic prophylaxis can prevent recurrence of UTI in pregnancy. Thank you for a patient hearing. If there are any questions, you can just go ahead.
Yes, sir. Thank you very much, sir, for this nice presentation. And meanwhile, I have received few questions. So if you allow me, then we can have a discussion on that.
Yes, sure.
Sir, my first question is, in case of menopausal women with UTI, can we use probiotics, and will it be of help, and what is the duration of the treatment in that case?
Yes. So in postmenopausal women, we know because of less amount of estrogen, your vagina gets atrophied, your all the epitheliums are atrophied, because of which the bacteria can easily implant in those regions and can cause infection. Not even urinary, but even endometritis and all can be common during postmenopausal. So in such cases, use of probiotics would be helpful because it's going to prevent an overall general infection. Also, use of limited time use of hormones like estrogen can be helpful in such patients, especially when they are not responding to routine treatment.
Okay, so. And sir, another question is in UTI during pregnancy, what is the safe prescription? Means what will be your approach of the treatment without having any complication at all?
Okay, so if we are having a patient, so first and foremost, we need to do a urine culture and find out if the patient is having asymptomatic bacteriuria or no. Symptomatic patient, obviously, we are going to treat, but if it is an asymptomatic patient, so the first line of agent nowadays, what we prefer is fosfomycin, which is found to be safe in pregnancy, given as a 3-gram single dose at night time. Okay, in addition to this, we can provide, for example, as we talk about urine alkalinizing agents, use of citrate, potassium citrate, D-mannose, and all these agents would help in preventing as well as in treating your cases with asymptomatic bacteriuria. So once these patients are even treated, we would recommend them for at least for say 7 to 10 days to take all these agents so as to prevent any recurrence. So the prolonged treatment is slightly helpful in such cases, and use of this additives also is very helpful.
Okay, sir. And sir, my last question, it is that what is your means observation on UTI? UTI depends on a particular or specific class or strata related to hygiene habits or so, or it is to all class of people who are doing everything well?
UTI, we say per se would affect, does affect all class of women, but more so it affects in the patients with those socioeconomic strata. Also, we already talked about hygiene, how it would affect, and simple things that can be behavioral changes that can be done so as to prevent such infections. So the knowledge of all these behavioral changes is very important. The onus is on us doctors to be educating our patients regarding this. So obviously, per se, going back to your questions, the lower economic strata, the patients are more affected because higher socioeconomic status, maybe, once they have been infected and this behavioral changes, we have told them they're going to follow it for a longer period of time, and the chance of recurrence in such patient would be less.
Okay, sir. And sir, I could not find any other question. So if you allow me, then we can close today's webinar, sir.
Yes, sure. It was a pleasure to be talking to the August audience. Thank you so much for having me here. Thank you, Shield Healthcare, for having me.
Thank you very much, sir, for your valuable time. And in future also, we will look forward for talk from you in other topic also. So thank you very much. Thank you once again for your valuable time.
Thank you. Thank you. Bye.
Thank you, sir.